All right, looks like it is 12 o'clock on the dot. So I just wanted to welcome everyone. Good afternoon. My name is Olivia Henze from the New England QIN-QIO, and I'll be your moderator for today's webinar, Using a Value-Based Purchasing Tool to Improve Quality. The Quality Innovation Network Quality Improvement Organization, New England QIN-QIO, works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end of the presentation, or you can pose a question in the chat box. Make sure to send to all participants, and I will provide you instructions on how to ask questions and unmute your phone line at that time. At this time, I'd like to introduce Jean Dufort with the New England QIN-QIO. Jean is the regional lead for the New England QIN-QIO's hospital aimed at the Better Care at Lower Cost program. This program looks to align and coordinate related CMS programs, including CMS Value-Based Purchasing Program. Jean, the floor is all yours.
Hi, thank you, Olivia. It's my pleasure to introduce Mr. Vincent Dufort, Advancing Simplicity in Healthcare. When Mr. Dufort defended his doctoral degree at McGill University, he was congratulated for conveying the information with a dissertation of fewer than 100 pages. With more than 20 years in the Medicare quality improvement arena, he continues to push the simplification of complex tasks to the application of programming and paring down questionnaires. His goal is always to cut through the chatter to get to the actionable information. In addition to co-owning a business in New Hampshire, Vincent is currently working as a contractor for the Northeastern Regional QIN-QIO. When he isn't buried in spreadsheets and programming, you might see Vincent cooking, practicing massage therapy. He is a licensed massage therapist in New Hampshire while running with his business and life partner, Rebecca. Vincent, the floor is yours.
Thank you, Jean, and thank you, Olivia, and welcome, everyone. As Jean mentioned, I've been around quality improvement for a little bit of time, and this is your opportunity now. If your destination is not to improve quality in your setting, you can walk out of the room. That's our destination today is talking about improving quality in the healthcare arena using this value-based purchasing tool, which is essentially a spreadsheet with a lot of really messy calculations behind the scenes. So I want to start off from the end of my presentation, which is the acknowledgement. First of all, I'm indebted to the hospital quality improvement people, you folks on the call, the nurses, volunteers, the administrators, and the docs who are dedicated to quality improvement in the healthcare facility. There's an underlying thought of that quality improvement is somewhat driven by finance, and I appreciate that, and that's kind of what we're talking about today, is looking at how can we get the most for our intervention. But this quality improvement, improving the outcomes for our patients is definitely in our minds as well. I'm also thanking the New England Quality Innovation Network Quality Improvement Organization, the QIN-QIO, the regional QIO for the 6 states, Maine, New Hampshire, Vermont, Rhode Island, Massachusetts, and Connecticut, who saw that value in this spreadsheet and gave me the go-ahead to keep working on it and present it to you today. Spearheading that was Jean, who just communicating with, and she's really responsible for a lot of the usability of the spreadsheet. I did the formulas and all of that, but I take no credit for any of the aesthetics of it, the color or the setup of the charts and the graphs and so on with the tables. That's really something that Jean did, and I'm very grateful for that. Gail is also involved. She's, I'll call her my boss at the QIN-QIO, and I'm grateful for her go-ahead nod on this project. And then Olivia, who you heard from earlier, who's communications specialist at the QIN-QIO, who made this presentation possible by setting up the WebEx and holding my hand in a dry run last week and so on. So we'll start off with the WEES of the VBP2. The WEES, this is from a mentor in Belgium who talks about WEES because in Belgium there is, my understanding in Belgium, Netherlands area, there's not a word for W, so they use we instead, and that's who, what, where, and why, and how. Right now, today, we're going to focus on the how, which is what this tool does practical. So let's just use it and find out how to use it, what tabs there are, how we can look at from year to year the changes, and how we might look at a particular year to influence our decisions in quality improvement. There's also some background tabs which will explain a little bit the logic behind each individual tab and the summary tab as well. That can be helpful when you're looking across the years and not just at a specific year. We're going to do some working scenarios, and I'll leave it to you to figure out in your own settings how you can use the tool to drive quality decision. I'll go through a couple of very quick possibilities, and really your data will help you to understand a little bit better how you can best use the tool to focus on the pieces that are of value for you in your individual settings. What's left out today, and you can all agree that big site releases, we won't be talking about the formulas and the cells. We won't be talking about who, what, where, when, and why. We won't be talking about how you form committees and what personnel you want to involve and all of that. We won't talk about the details of the measures, how to go through the federal register to find the information on what is involved in the measure and the tools and the parameters and all of that. We won't really talk about where you target the changes for improvement if that's an individual basis. You'll have to go back and play around with your data and figure out where you can likely impact quality in the facility. We'll go through an example or a made-up example just to show you some of the logic, and then you can go home and play with it. Go back to your office and play with it. That's really the good part of this tool is that it allows you to develop different scenarios and see what your outcomes will be. We won't talk about timelines and definitions and why these fiscal years have been developed and what measures depend on what parts of what fiscal years. That information is available, and Jean will speak about where we provided that information on the website later. It's just too much to cover today, and because I'm going back to advancing simplicity, and I keep remembering that, I want to keep it short and sweet to the point and give you something of value today. We won't talk about why the value-based purchasing initiative exists or really how you can improve your outcome, because that's up to you to decide. When you use this tool, you'll play with it and you'll figure out what you can do and how you can make changes. So let's start off right away with the tool. It's a spreadsheet. Again, as I mentioned, Excel spreadsheet that has tabs at the bottom, as you can see here, with the different years, going back to fiscal year 2013 all the way to fiscal year 2018. And as we have more current information, we will add the newest fiscal year when that comes out, when we have that developed. And as you may or may not know, each fiscal year had different scores, contributing to the overall score. We're not going to get into the detail of that or how it changed from year to year. You can look at it, or if you're already familiar with the value-based purchasing initiative, then you'll know that in some years certain measures came up and other measures dropped off. And another part of the as I mentioned in the opening, another tab is the executive summary, and that gives you an overview from year to year under the different initiatives, the summary clinical care, the hospital performance, hospital outcome score, HCAHPS, and so on. And depending on the measure, knowing that, for instance, the hospital outcome started in 2014, the first year of data is the fiscal year 2014. There's nothing earlier than that, and others have starting at 2013. We also have two other tabs, the domain rates, which are basically just background information on what domains existed when they existed and what the weighting of those domains. So we'll talk about that a little bit later, just to give you an example, in the example that we're going to go through. It is basically telling you that in a particular year, for instance, the clinical process of care might have changed, or the patient experience domain changed a little bit. If you see here, the clinical process of care did change quite substantially over the years. And that's important for you when you look at your different possible scenarios and how you're going to change the overall score in your hospital and change your reimbursement rate. And then on the final tab, which is baseline and performance period, we have the time frame, which gives us when the measure came into effect and what the fiscal year actually is. So it's here in the spreadsheet, but we won't go into the detail of that. I'm just showing you the navigation of the workbook. So let's start off where we go back to, let's say this is fiscal year 2017, that tab 2017, and we get to the HCAHPS score, and we're going to enter two columns of data. One is the baseline score, and the second is the performance score. The baseline score is and let's just imagine this is the information you have right now. You have the baseline information for the HCAHPS. You enter that. You may not have the performance score, and that's what we're talking about today. Let's put in some numbers here. Let's say we start off with communication at 73, and let's say we think we might get it up to 75. How is that going to affect that particular communication score, and how will it affect the overall dimension for HCAHPS? And similarly, we have the hospital safety measure score, of which you might have partial information to the baseline. You may not have enough information for some measures within that domain, but that's okay, because in this particular instance, as long as you have two, it gets you a usable score. And what we're looking at here in the comparison between the two is, you see how these numbers are entered. Here is a 73 and a 77 and a 75. That's because the HCAHPS scores, when you get them, that's the format they're in. This is 73%. Some of the measures, for whatever reason, and I'm not going to get into that now because, frankly, I don't know why, they came in as 70% is 0.7 instead of 7. So on the next slide, we'll see how that's important. So the score that's entered here, the format of the number is critical. So if you have 73% and you enter it as 0.73, you're not going to get a good answer here. You have to enter it the way, and the trick is the format is the same format as in the achievement and benchmark column. So here we have the format of 78.19, so you know this is going to be, the format is going to be 73, not 0.73. And similarly, here the achievement threshold and benchmarks are 0.457, 0.845. And that means that you better have the value in the baseline and the performance in the same format, 0.7 and 0.5, to get a reasonable answer in the end. And here's an example just to show you that what happens if you put the 0.73 instead of the 73 and 77 and so on. You get nice. That's not what you're expecting. You think you're doing better here, but what's going on? I'm going from 73% to 87. How come I'm getting zeros? It's because the format is wrong. And if you see here, we corrected the format to 73, 77, and so on. It gives us usable scores. It gives us a base and a base score and a dimension score and so on. We won't go into what that means. That's for another day. That's not under the header of simplicity. That's way outside the header of simplicity, so I don't want to talk about that. I just wanted to let you know that when you have data to enter in these columns, ensure that you're entering it in the same number format as you have in the achievement and benchmark columns. And the other thing that, just to let you know, is that, for instance, in some instances, you may not have all of the information. You may not have enough baseline information. The measure may not be a valid measure for your facility. That's okay, as long as you have sufficient information to calculate a performance score. And that's determined, it depends on the fiscal year. Sometimes you need only 2 scores, sometimes you need 3 scores. We have put the formulas behind the scenes here so that this number reflects the fact that there is missing data, and it will take whatever value this should have spread out across the others, and it will increase that number. So if we had just done a straight-up formula without accounting for missing data, we would come out with 26% here. And that would have been kind of sad because it would have not been the true answer. But you're really looking towards a 52%. That's taken care of behind the scenes. Just wanted to underline that sometimes you will have missing data, and that's okay. You can both in the tables have missing. I'm going to go back a couple of slides here. In the tables themselves, you can have missing data if you don't have information. In this particular hospital safety measure, I believe there's a minimum of two scores to make up a domain. If you have at least 2, it's okay. You're going to get a value. If you have fewer than 2, if you only have 1, you'll get an NA in this. And that's okay. You don't have, it's just part of the way it's reported. And so this is an adjustment that's made, and you see here there are some lines where there are no cases in the clinical care, and this is a totally fictional case. It may not be realistic. I just wanted to show an example of what would happen if you didn't have information in a particular area. Now here we go to setting up the scenarios. We look at for instance, if we're looking at the clinical care process, the value of clinical care, the weighting of clinical care in FY 20, whatever year this is, 17, I believe, is 5%. So the change here, if you look, the change between a clinical care process of 10 to 90, it looks like it's a huge change. But the difference here in the overall in the hospital performance, because clinical cost is only 5%, it goes from 45 to 53. It's kind of tiny. You'd think that with this huge jump from a 10 to a 90 that you'd get a big outcome here, let's call it a big bang for your buck, and really you're not getting a lot. You're getting a little bit. You're getting 45 to 53. It's still something, but when you're playing around with your numbers and you're creating different possibilities, different scenarios, you just pay attention to that. So you might have a very low clinical process score in your baseline. You may be able to get it to 90% to very high. But look at this number. Is it going to be very meaningful in reimbursement for you? And the answer on this one is perhaps let's look at another possibility. And so let's look at the HCAHPS. The HCAHPS score is worth 25% of the total. So let's say we start off with an HCAHPS of 40 and we get it up to 98. That's, again, it's not as big a jump as the clinical process from 10 to 90, but if you look at the change to the hospital performance, given that it's a 25% contribution to the overall score, we're going from 53 to 82, which is a substantial change. Now, again, because the HCAHPS overall rate is 25%, a smaller change, and it was a smaller change to the HCAHPS overall than what we've had in the clinical process. It resulted in a substantially larger change and a larger reimbursement again. And I'll just let you know that anywhere that you can change information in the spreadsheets, the cells have been left unlocked, and any of the places where the numbers are fixed, where the data is fixed, you won't be able to change. So, for instance, in the achievement threshold, the benchmark, and so on, just as a side note, you're only going to be able to, and you won't be able to break anything, you'll only be able to mess around with numbers that you have control over, for instance, these baseline scores and the performance. So, just to let you know, don't worry play around with it as much as you want, because most of the spreadsheet is locked unless any of the formulas have been locked, any of the cells that are critical cells that are threshold and benchmark cells have been locked, so you won't be able to motion around with that and break things. That's good, because we want you to play with stuff and we want you to get some value out of it. So in summary, and I wanted to say this at the beginning, but this is lunch. This is your lunch break, and I wanted to honor that you folks in the hospitals are not wanting to spend any more time than you need to. And again, going back to simplicity, I want to take as little of your time as possible and give you something that's valuable. This tool is simple to use, and I believe it packs a punch. Going back to that slide where we had the incorrect number format, just remember that. When you're playing around, if it's asking for a 72 or a 0.72, just ensure that you've got the right format in there. Missing data is okay up to a point, and any of the tables that allow missing data will usually somewhere say you can allow up to 2 missing points of information, or you need 2 points of information to have a valid measure. And even in the summary table, it's okay to have missing data up to a point. If you get below that threshold, the table will tell you that there's not enough information to calculate anything valid. And as we went through that slide where the one domain changed substantially and the overall did not change much, and the other one changed a little bit less than the first one, and yet the outcome was substantial. The weighting, that's called the weighting of that particular domain, does impact the effect of the change. Now, a final caveat is that the likelihood of the ease of change in a domain needs to be taken into account when determining the target. It's not something that might not be logical right off the bat. So you may see something that as you're playing around with your numbers, as you're punching in different scenarios that you're thinking of, think also how likely is it to change anything in this domain, or the pieces in that domain that we want to change. Sometimes it's just the changes that we're looking at are just too difficult, and we don't have a reliable way of moving the number. And so if we're looking at something that is depending on patient satisfaction, and we don't have a good grip on how we're going to affect patient satisfaction. It's a very time-consuming and costly endeavor. We might choose that, okay, the number is already pretty good, getting it much higher is going to be a big challenge. Very expensive. We're going to have to weigh that. We're not going to talk about that today, certainly. This is just something that to put in your mix, in your recipe when you're playing around with the spreadsheet. That needs to be taken into consideration when you're determining the target area. And with that, I will hand the floor over to if there are any questions, comments.
Sure. Thanks, Vincent. If you would like to ask a question, you can pose your question in the chat box. Make sure you're sending it to all participants, or you can press #6 to unmute your phone line. Again, #6 to unmute your line, or you can pose a question. Oh, looks like we have a question here in the chat box. Vincent, from Christina, I noticed this had dollar values in it. Is it hospital specific?
Yes, it is hospital specific, and that is one of the fields where you can use your own information. When you know what your withholding is, your dollar amount withholding, I just put in some numbers, fictional numbers. I have no idea what the reimbursement is on a facility-by-facility basis. I have no idea what the withholding is in terms of dollar amount, but that's the number you want to put in there. What is your value-based purchasing withholding for that fiscal year?
Thanks, Vincent. Looks like there is a question from Gwen and Jane. The slides from the presentation are available. They were sent out in a Day of Details email to all registrants. They're also available on our website, which I think Jane has provided the link. I'll provide it again. All registrants will also get a thank you email tomorrow that will have all of this information in it. Oh, there's the link. Thank you, Jane and Alex. Is there any other questions? #6, or you can pose a question in the chat box. Looks like there's another one from Jennifer. Vincent, I'm assuming that the only cells that are locked are the ones with formulas. The other cells may be personalized?
Yes. Actually, most of the cells are locked except the ones where you're needing to change information. Your baseline and your baseline score and your projected score, let's call it that, and the dollar amount of your reimbursement. So if you know that your withholding is I put in $2 million. I have no idea what I just needed to put a number in there. If you know what your 2% hospital DRG payment withholding is, that's the number you're going to put in that cell. That cell is unlocked. And the hospital baseline score and the hospital performance period score are also unlocked. I think there may be one cell where an achievement threshold and a benchmark is unlocked, especially if it's one where we don't have a value for that. So any cells that have a value or have calculations are locked, otherwise not.
Thanks, Vincent. Looks like Christina has a couple questions here. The second one, how do we get the tool? Jean, can you speak a little bit more on that? I know that that is available. Would you be able to give us some more information about that?
Yeah, Alex is actually providing the link right now. You can go onto the website to download the tool, and We also have up there a value-based purchasing guide and instructions for the tool.
Great, and I would like to, oh, perfect, thanks, Jean. And I do want to let everyone know that all this information will be available specifically in a thank you email tomorrow. So if you don't catch it in the chat here, you can get it on the thank you email tomorrow. That will be coming, that will be going out from Jean.
And Olivia, I think a question from Christina regarding 30-day mortality information.
Yeah.
The mortality information, I believe, Christina, is sent to hospitals in hospital-specific reports before it's reported. Is that? I guess I need a little clarification around the question. You can hit, is it #6, Olivia, to unmute?
Yes, or if you want to specify in the chat, or if it's easier, #6 to unmute, Christina. Hello. Can you hear me?
Hi. Yep.
Hi, this is Christina. So I just didn't know. So, yeah, I know we get our reports ahead of time. I just feel like that's so, you know, we'd like to know our information as far in advance as possible. So I didn't know if you were tapped into any further resources. Or I keep hearing there's a database out there somewhere that we could maybe utilize. I didn't know if anyone knew anything about that, or if that's real, or if it's just some phantom thing I keep hearing about.
Oh, I don't have any way to get the 30-day mortality information, the Medicare information, any quicker. And I do realize, it's also 3 years worth of data, and it can be very old.
Right.
It is old data. I could make a suggestion is trying to utilize, and I know resources are tough, but trying to utilize your internal resources, to track mortality. That way,
How would you suggest that?
I would work with IT. I know from my past life, that's what we would.
I mean, we track internal mortality, but this is mortality after discharge.
Oh, outside of discharge. I'm sorry, Christine, I don't know. I mean, I can do a little research around it, but as far as I know, unfortunately, you don't see it until you see those reports.
Right. Okay. I thought there was a death registry out there, but that's the phantom rumor that I keep hearing. So, no, that's all right. If you knew, that would have been great. That's all. No worries.
All right. Thanks, Christina.
Thank you. Any other questions? #6 for the phone, and you can pose a question in the chat box. Jean or Vincent, do you have any last-minute comments you'd like to make?
I just wanted to say that there will be some more background information up on the links that Jean will provide. There's a summary PDF that talks about year by year what the scores are and what they're made up of and what the baselines and so on are. So that, look forward to that. I think it's a very well-designed, developed tool that shows you what year to year what the measures look like.
And this is Jean. I'd just like to add to that. We will be we'll be doing a satisfaction survey, but beyond that, I'm going to be looking for a couple of facilities to participate with me in using the tool to see, exactly where its strengths are and how that might help other providers. And so look for something from me. I'll be reaching out.
Thank you, and thanks to Jean and Vincent for thanks to Vincent for a great presentation, and for Jean for all your help with this. I just have a few last-minute announcements before we end. When you close out of this webinar, as Jean mentioned, there will be an evaluation that will pop up on your computer. If you could please fill that out, we'd really appreciate it. If you don't have time to fill it out right now or you're sharing the computer with someone else, as I mentioned before, you'll receive an email tomorrow morning. It'll have the link to the evaluation as well as the link to the event page on our website where the tool and all the other information will be housed. Again, the PowerPoint presentation is already posted on the event webpage, and within the next few business days, a recording and a transcript will also be added. Thank you again for attending. Thanks to Jean and Vincent, and I hope everyone has a great day. Thanks, guys.
Thank you.
Thank you, Olivia.
The leader has disconnected. The conference will be terminated in 5 minutes.